Hello everyone, myself Dr. Sourav Talukder. Today as a guest we have the honor of having Dr. Chaitali Parekh. She's a renowned musculoskeletal radiologist currently based on Mumbai. So welcome Dr. Parekh.
Thank you, Dr. Sourav.
Can you let our viewers know one thing? The ultrasound guided musculoskeletal injections for various joint pathologies is creating a new arena of hope for the patients who are suffering from the joint ailments. So can you elaborate the role of the radiologist regarding the ultrasound guided joint injection, the indications where we can help our patients?
So these joint injections or soft tissue injections, bursa injections, they are very helpful for people who are into sports. And as more and more people are entering into sports, not just games, but day-to-day life, people
Absolutely.
want to play badminton or table tennis or cricket and land up with injuries. It really helps them to heal faster, get on to physiotherapy faster. The idea of the ultrasound guided injections can be multiple of drugs. The most commonly used is a local steroid or the cortisone, which is a long-acting steroid that we use. Now, just like I tell my patients, so just like people who have asthma, we do not give them oral tablets or IV steroids, we rather give them pumps. And the idea is to localize the steroid only within the lung so that it does not enter into the bloodstream. Similar is the concept for ultrasound guided steroid injections. You only inject within the joint or within the bursa or around the tendon. You do not inject inside the blood. So they are much, much better than oral steroids or IV steroids that you inject inside the blood because they will not cause any systemic body effects.
Absolutely.
So this is the main query that the patients have, that because everybody knows that steroid has side effects, they want to know that what side effects I land up in. But believe me, you do not get those body side effects that you get with oral steroids. It is just within the joint or in the bursa or around the joint.
Absolutely.
So that is the biggest advantage. Time and again, these injections have been done. Initially, they were done blind. It was not done under ultrasound guidance. The advantage of doing it under ultrasound guidance is the most of the places there where you want to inject, it's only 2 or 3 millimeters thick. Now,
Absolutely.
your needle is also 1 millimeter, 1 to 1.5 millimeter thick. When you do it blind, you are not sure if your needle is actually entering that particular joint
Area.
or bursa or not.
Yeah.
But when we are doing under ultrasound guidance, we are 100% sure. Every moment when you're trying to put in the needle and when you are injecting, you are looking on the ultrasound screen and making sure that the injection is going into the right place. Now, why that is important? If I do not put the injection within the joint for an intra-articular injection, if it goes outside the joint, the patient will not get any benefit.
Absolutely.
So it is very important that it has to enter that particular location, otherwise it will not benefit the patient. And so the trend is changing from blind injections to now ultrasound guided injections, and that is why this is shifting more towards radiologists who are
Absolutely.
trained under ultrasound. It's not just steroids. We also use other drugs like protein-rich plasmas, where the blood is collected, about 10 to 15 ml of blood is collected from the person's body, like any blood collection.
Absolutely.
It's centrifuged, you get the plasma. Now that plasma is very rich in growth factors and nutrients which are required for tendon healing, for ligaments healing, and then it is injected back at the site of tendon tears or ligament injuries in order for them to heal it faster. You also use something called as Synvisc, which is a form of hyaluronic acid which is used in arthritis, particularly knee arthritis patients. So who all should get these injections done? I would suggest someone who has a recent injury or maybe has suddenly started developing a pain in one of the joints. The pain is not subsiding over time. Usually the first line of treatment which the orthopedic surgeons will tell you is physiotherapy, and they are correct. But if someone is in a lot of pain and not able to do physiotherapy, that is when you want to do an ultrasound guided injection so that your pain component is taken away, and then you can do a physiotherapy. So it is not the only treatment. It goes in conjunction with physiotherapy, which is very important. For athletes, I would say, who want to get back into the game faster, they can use a steroid shot, just to tide over that game period. And then later on, they can do a PRP injection for the healing of the injured tendon or ligament faster. For old people, where there is severe arthritis. There's a lot of pain. They cannot move their shoulders or knees, and surgery is off the table because of age, because of comorbidities. You're not getting anesthesia fitness. For them, these intra-articular steroid or Synvisc injections can help them to tide over pain. Even if they are not able to do physiotherapy because of age, just routine movements of the knees and shoulders is good enough for them to tide over 6 months to even 2 years of time. And when the pain comes back, you can take another injection without any fear of any side effects.
Okay. Thank you, ma'am. So, can you please elaborate the most commonly injected joints and the various pathologies in this joint for which the injection usually we do the injections?
So the most common joint that we inject in current times is the shoulder joint. Usually, the most common thing is because shoulder is more utilized. So we tend to get a lot of debilitated when your shoulder is affected than when your knee is affected, because you really cannot move your shoulder around.
Absolutely.
And you want to use your hands for a lot of stuff. So there are a lot of injections that are done around the shoulder. The most common ones are injection in the shoulder joint itself, which is the glenohumeral joint. And that is done for frozen shoulders, which is one of the most common indication. The frozen shoulder is nothing but thickening of the joint capsule. So you land up injecting inside the joint. It acts on the capsule from inside, reduces the inflammation. The pain goes away, the movement becomes free. And then the patient goes for physiotherapy so that it does not come back.
Absolutely.
Also, for there is a structure called labrum inside the joint, just like you have meniscus in the knee, and there can be tears. After the age of 40, most of us have a labral tear, and usually they do not require surgery. But the pain is coming from the labrum, so that's when again your joint injection will be helpful. Then with age, your tendons, they tend to degenerate. There are changes that develop inside the tendon, which we call tendinosis. In the tendinous tendon, even small jerks can land up in partial tears. Now, usually you do not want to operate a partial tear unless a tendon is completely torn. You do not want to undergo a surgery for the same. So what you do is you put in an injection in the bursa, which takes care of the pain. It may or may not help with the healing of the tendon. It usually does not heal the tendon, but then that is not the main criteria for doing the injection. The idea is to take the pain away and then go for physiotherapy for strengthening of your muscles. Technically, all the movement load should be taken up by the muscle, but when your muscles are not strong enough, they are taken up by the tendons, and that's what results into tendon tears. So you want a partial tear to not land up into a complete tear, and that's where you want to strengthen your muscle, but you cannot do it with pain. So you give it a steroid injection, you take the pain away, and then you go for physiotherapy.
That's so encouraging to know everything regarding the joint injection. So, ma'am, can you please elaborate us regarding the role of the steroid or any kind of injections in the osteoarthritis or any inflammatory arthropathy of the joints?
Right. So, we do tend to give steroid injections in osteoarthritis. It is not the first line of treatment for knees, because knees there are very good surgeons who do knee arthroplasties, and that is pretty much required. But you need to do it in knee when, as I said, old age people, they are not able to undergo surgery for comorbidities or advanced stage, a lot of diabetes and all of those things. That's when you want to give an intra-articular, either a steroid or a Synvisc. For the shoulder joints, usually shoulder arthroplasties are not so common. Because the success rate isn't that very much great. Yes, it is successful, but again, if it's an older age patient, you do not want to do a shoulder replacement surgery. So again, you can tide over from the shoulder pain with the steroid injections. Now, for someone who's 80-year-old, for them, really range of movement is not much important. They don't want to really exercise their shoulders out. But the main idea is to get rid of the pain, right? And so getting rid of the pain is possible when you do a shoulder intra-articular injection. Sometimes, if the pain is too much and only intra-articular injection is not benefiting, you can also do a nerve block with the steroids. So the steroid, sometimes even the nerve is inflamed. So you put a local anesthesia and a local steroid around the nerve, which is taking the pain sensations from the joint to the brain. So once you numb those nerves, what happens is the pain sensation does not go to the brain and the patient is more comfortable moving the shoulder around. So these are the main indications that you do for intra-articular injections for the arthritis.
Oh, thank you, ma'am. One more thing. Another common entity is a decoy tendinosynovitis, where there is excruciating pain on the lateral aspect of the wrist. So, what are the radiologist has to offer regarding the treatment of the decoy veins?
So, not only decoy ones, but any tendon pathology, any inflammatory synovitis of the tendon sheath, you can inject local steroid. You are not supposed to inject inside the tendon, and therefore it is very important not to do these injections blind, because as I said, I don't know if I'm going blind, my needle is inside the tendon.
Absolutely.
Or is it between the tendon and the tendon sheath. The space between the tendon and the tendon sheath is practically negligible, and so you want to always see under ultrasound. What you do is you inject the local steroid and local anesthetic between the tendon and the tendon sheath, and that's how it it acts on the tendon sheath from inside and reduces the inflammation. So this can also be done for inflammatory conditions like rheumatoids, especially for those patients who are, on advanced DMARD drugs, because again, taking DMARDs is putting heavy drugs into your blood system. They will have their side effects. But if it's a focal synovitis in one particular joint or one particular tendon, you can always do a local steroid injection to get relief from that inflammatory synovitis. And not only decoy ones, some people have this trouble of trigger fingers.
Absolutely.
Yeah, that also can be done under ultrasound guidance. Not only just injection, but for those who've got a very advanced trigger finger, there's a lot of pain. In fact, they're not able to straighten their fingers out. You can do an ultrasound guided release of the pulley. So the pathology is the pulley is thickened. Usually the surgeons, they release the pulley, but they cut open and they just cut the pulley out. You can also do it under ultrasound guidance. So the advantage is there is no surgery, there is no scarring, there is no hospital admissions, nothing is required. It's an OPD procedure. You just come inside. It's done under local anesthesia. So no anesthesia fitness is required. And under ultrasound guidance, you try to tear the pulley so that it does not hold the tendon tight. I'm not saying it's 100% result. It may or may not help. Usually it helps, but there is a good enough number of patients who do not benefit from it. Those patients can then go for surgery. But before directly landing for surgery, I feel it's a good idea to try this one out, and it's not an expensive procedure as well.
Absolutely. So surgery can be kept as an alternative or the second line choice for the trigger finger.
Yes.
Absolutely, ma'am. Another thing I want to ask from you, whether the ultrasound guided procedures has any role in case of carpal tunnel syndrome.
Yes. So just like trigger finger, even for carpal tunnel, we do two types of procedures. One is if it's not a very severe carpal tunnel, just some injection around the nerve, which is called as hydrodissection. So what happens is the median nerve is going inside the carpal tunnel, which is a very close space. Now there can be adhesions that develop between the nerve itself and the tendons and the ligament, or which is called as the flexor retinaculum, above the nerve and the tendons below the nerve. So the nerve is not able to move freely, and that's what results into carpal tunnel syndrome. So one is hydrodissection, where you just inject fluid, about 15 to 20 ml of fluid around the nerve to break these adhesions and free the nerve from all the bindings. And then you give a small amount of local steroid again around the nerve to reduce the inflammation of the nerve. So that will take care of the pain as well. For someone who has advanced, you just like in trigger finger, how you can cut the pulley under ultrasound guidance, you can also cut the carpal tunnel ligament, which is called as the flexor retinaculum, under ultrasound guidance as well. So that is also the surgery that the surgeons do. They open up and they cut it out. We can do a same thing under ultrasound guidance. Again, it is not always 100% result, but it can benefit to most of them. For those who are not getting a benefit out of it, can obviously opt for surgery later on.
We gather a mass of information, a lot of information from one of the most renowned MSK radiologist of our country, Dr. Chaitali Parekh. So the take-home message, I think, Madam has elaborated the various pathologies for which the ultrasound-guided injection or the small procedures can be helpful for a lot of patients. And the take-home message, I think, Madam, the procedure must be done under the ultrasound guidance, under the supervision of an experienced radiologist, because it benefits the patient and it reduces the chance of complications and it maximizes the potential benefits to the patients.
Very correct. That's absolutely important.
Again, thank you everyone for listening to our video, and thank you, madam, for your such a nice sharing of knowledge from your side. Thank you so much.
Thank you so much.